Welcome to Senadhipan Education Foundation once again. The roots of education are bitter, but the fruit is sweet. We started this educational journey way back in 2007 by releasing a brochure from Holy Cross Hospital, Kottayam, Kerala, India. The brochure was released by Professor Antonio Longo. Then we launched Senadhipan Education Foundation in 2012 by releasing a set of educational DVDs by Professor Sion Han Kim on 30th of January 2012. Then we started having fellowship programs, hands-on training programs in basic and advanced laparoscopy surgery, training programs in endoscopy and therapeutic endoscopy and lab suturing. These are the visuals of some lab suturing training course which is happening. And these are the visuals for the trainees for endoscopy program. And we have entertained international fellows from different parts of the world, especially from African countries. We give hands-on, but upon one condition that they should have a National Medical Council registration from India. We offer 6 months and 1 year fellowship programs. Recently, we visited Tanzania to train surgeons there in Tanzania itself. And with the advent of COVID, we started live programs in online. We did the first Facebook Live in Facebook Live with a lab anterior session. And we did a lab Whipple session YouTube Live. And the link was shared to the members of Senadhipan Education Foundation. Then we started having webinars with world leaders, and the logo of Senadhipan Education Foundation was released by Professor Palanivelu. In the season 1, we had a lot of world leaders who contributed to the webinars of Senadhipan Education Foundation, including Professor R.J. Hield, Dr. Peter Cotton, Dr. Sugar Baker, Dr. Leroy, Dr. Armando Melani, Dr. Jorge Diaz, Dr. John Windsor, Dr. Tsuyoshi Eto, Dr. Robert Aldrich, and Dr. Guillermo, Dr. Johan Renard, Dr. Alfred Allen Bunafe, Dr. Go Wakabashi, Dr. Nakakawa Yuchi, Professor David Keon, Dr. Guido Toselli, and Professor Vire Allen Clavian, Dr. Oli Linguist, and many more people, including Professor Philip Wuchu. We conduct international fellowship programs in SPB surgery, colorectal surgery, upper GI surgery, endoscopy surgery. HPB surgery fellows go to Tokyo Medical University. These are the visuals of the people who went to Tokyo Medical University under the training by Professor Nakakawa Yuchi. This is another group of people who went to Nakakawa Yuchi. And because the applications are more than 500, we thought of having an award program. We started SEF Ekalavya Award in 2025 and invited video abstracts from different corners, and we received more than 73 video abstracts, and of that we selected 5, and we had a podium presentation of 5 videos, and Sujata Sai from Adayar Institute won the Ekalavya Award. She will be going to Tokyo Medical University for free fellowship program in February 2026. So we conducted a international meeting offline. We had 117 faculties, including 11 international faculties. And the last data submission of video abstracts for the next program is extended to 15th of December 2026. We will be having our second international program, offsite meeting on 9th and 10th of May 2026. We have presence in 100 countries and chapters in 51 countries. Ambassadors are there in each country. We have collaboration with many universities. These are the visuals of ambassadors of Sainath Education Foundation in different countries. Our motto is disseminate surgical knowledge in all the nook and corners of the world with zero financial motive, so that a wide spectrum of patients are benefited worldwide. Today, we are honored to have Professor Mukesh Harisinghani and Professor Sudheer.O.V, who are experts in their fields. Professor Mukesh Harisinghani is actually supposed to be one of the best MRI person in the world, and he will be speaking on MRI in rectal cancer. He is the authority in that area. And Professor O.V. Sudheer is actually a friend of mine. He is he is the HOD and Professor of Surgical Gastroenterology, Amrita Institute of Medical Sciences, Kochi, Kerala. Now we have Dr. Sneha Joseph, who is a DNB trainee in surgical gastroenterology in our unit. She'll be officially introducing the moderator and the speaker. After that, we'll be handing over the mic to Dr. Sudheer.O.V. So before that, please rename your device name by yours. Raise your hand before asking questions directly. Please enter the place of login and mail ID in the chat box. This is for calculation of the screen time for the certificates. The request for certificate should be sent to senadiban@gmail.com in 48 hours of completion of the webinar. So you can write to me at senadiban@gmail.com. I am handing over the mic to Dr. Sneha.
Thank you, sir. Good evening, respected professors and dear colleagues. I am Dr. Sneha Joseph, resident at SK Hospital Trivandrum in the Department of Surgical Gastroenterology, headed by Dr. Baiju Senathaban, sir. To begin with, I would like to thank our dear teacher, Dr. Baiju Senathaban, sir, for giving me the opportunity to be part of Senathaban Education Foundation.
Can you increase the screen size?
Yes, sir. Is it visible, sir?
Not visible. Can you read it?
Yes, sir. Yes, sir. Speaker for the day on the topic MRI for MRI in rectal carcinoma is Professor Dr. Mukesh Harisinghani, sir. Sir is Professor of Radiology at Harvard Medical School and Director of Abdominal MRI at Massachusetts General Hospital in Boston. Sir has more than 38 years of experience in the field, and sir graduated MBBS from Grant Medical College and Sir JJ Hospital, and continued to do residency and fellowship at Massachusetts General Hospital. Sir holds American Board Certificate in Diagnostic Radiology, and sir has expertise in diagnostic radiology, specializing in MRI applications in the body imaging, genitourinary radiology, and translational molecular imaging. Sir focuses on developing novel molecular markers imaged by MRI, and he's recently concluded translational clinical trials using magnetic nanoparticles for cancer detection and staging. The area of interest include cancer detection, molecular imaging, and medical imaging physics. Sir's notable achievements include holding the position of Director of Abdominal MRI at Massachusetts General Hospital, Section Editor for Genitourinary Radiology in the American Journal of Röntgenology, Clinical Discovery Program Director at the Center of Molecular Imaging Research at Massachusetts General Hospital. Sir has over 479 publications, 17,283 citations, with an H index 65 and I-10 index 191, and sir has edited over 5 books in his area of expertise. Very few of the recent publications in the late 2025 include imaging review of tubercular colitis and complications, prognostic value of MRI-derived features for biochemical recurrence after curative radiotherapy in prostatic cancer, Dr. PET-CT versus MRI neuroendocrine liver metastasis, prostate autosegmentation model for MRI with or without hydrogel spacers, an international study assessing the physician accuracy in delineating the prostate and urethra on MRI, and the role of MRI in diagnosis and pre-surgical mapping of endometriosis. And the moderator for the day, our beloved Professor Dr. Sudheer.O.V, sir. Sir is a renowned surgical gastroenterologist with experience more than 25 years. And sir began professional journey in 1999 and is currently serving as professor and head of the Department of Surgical Gastroenterology at Amrita Institute of Medical Sciences, Kochi. Sir's area of interest include laparoscopic bariatric and hernia surgery, minimally invasive and robotic surgery in esophagus and colorectal surgeries, surgical innovation and technique development. Recognitions include Sir has pioneered bariatric surgery in Kerala since 2005. Sir has performed over 2,500 laparoscopic hernia repairs. Sir has innovated techniques like two-pot TEP repair and later working in single-pot hernia repair. Sir has performed the highest number of minimally invasive esophageal surgeries in Kerala, and Sir is the early adopter of minimally invasive esophagectomy way back in 2003. And Sir has been trained in the same international centers in USA, Japan, and Korea. Sir has extensive experience in laparoscopic hepatobiliary and colorectal surgeries, and Sir has trained in robotic surgery under Professor Julian Nati at Samsung Hospital, Korea. Sir has held the positions of founder president of Association of Surgical Gastroenterologists of Kerala, executive committee member in the Indian Association of Surgical Gastroenterologists, executive committee member, the Association of Minimal Access Surgeons of India, holding the position of treasurer of the Indian Association of Pancreas. Research and audit. Sir has been principal and co-investigators in many studies, including the MASCOT study comparing ceftazidime sublactam for treatment of intra-abdominal infections, again tigecycline versus imipenem cilastin for intra-abdominal abscesses, again multinational studies for the efficacy of enoxaparin thromboembolism after major abdominal surgeries, and safety and efficacy of NXL 104 ceftazidime plus metronidazole versus meropenem in the treatment of intra-abdominal infections. Again, a part of phase 3 trial in the usage of prokinetic agents in the treatment of postoperative paralytic ileus. Sir is a lifetime member in the Indian Medical Association, Association of Surgeons of India, Indian Association of Minimal Access Surgeons, life member in the Indian Association of Gastroenterology, life member in the Obesity Surgery Society of India, and life member in the Indian chapter of International Hepatopancreaticobiliary Association, and a life member in the Association of Surgical Gastroenterology. Sir's contributions span clinical excellence, surgical innovation, and global collaboration, earning his recognition as a leader in the GI surgery. Sir has more than 29 publications. A few of the recent ones include analysis of complications following robotic donor hepatectomy, published in the year 2025, gastric tumor causing gastroduodenal intussusception and its laparoscopic management, published in the year, again, 2025. We welcome both of you esteemed professors to the forum, and we are privileged to have you here. Thank you so much.
Dr. Sudheer, the floor is yours. Thank you, Dr. Sneha.
Thank you, Sneha. Thank you, Dr. Baiju, for inviting me to moderate this very important lecture on MRI of rectum in rectal cancer. And I also welcome Dr. Mukesh Harisinghani to this forum. This is a very important topic. The MRI in rectal cancer is a very important topic, as the implication on a precision MRI and the quality of MRI has a profound impact on patient management. Whether the patient goes for a upfront surgery or a neoadjuvant therapy, or even the patient goes for a non-operative treatment, what I would say that solely depends on the MRI scan. And now there have been a lot of recent changes also in MRI interpretation, like the anatomical location of the tumor has been changed with the reference of, the description is changed with the reference of the sigmoid takeoff, the anterior pectoral reflection, the anatomical concept of the anal verge, in radiology, in MRI, the intersphincteric groove. And also there have been much change, many changing concept of the MRF, the mesorectal fascia involvement, and also the interpretation of the lymph nodes in cancer rectum, and the locally advanced tumor, ST4A, T4B. And also it has a lot of role in the primary imaging and also secondary imaging, like after a neoadjuvant chemoradiotherapy, to interpret whether it's a complete clinical response, either it's a near complete clinical response or incomplete response, which would decide whether the new paradigm shift in surgery as whether we can go for a wait and watch or non-operative treatment for this patient or local extension of the treatment. Anyway, without much further ado, I introduce the very important talk on the MRI in rectal cancer by Professor Mukesh Harisinghani. Thank you. Dr. Mukesh.
Thank you so much, Dr. Sudheer.O.V. And it's a real pleasure and honor. And, education being close to my heart, I truly am amazed, and I would like to congratulate Dr. Senadipan for a remarkable achievement in terms of percolating the knowledge to the various corners of the earth and also to bring the expertise to India. I think our physicians, they have achieved great heights, but it always is good to have a dialogue, international dialogue, so that various clinical practices can be exchanged and, the expertise can be also improved in the local environment. So I just wanted to confirm you can see my slides and you can hear me clearly.
Yeah.
Perfect. So thank you. So what we are going to do today is, go over some key aspects of the role of MR in rectal cancer. And we are primarily going to focus on pre-treatment MR. And so some facts we'll cover about rectal cancer, some of the key anatomical bases and how we perform the MR, which are critical for us to understand. And also some staging pointers and what are some of the adverse prognostic indicators on MR that we like to communicate so that physicians and surgeons like Dr. Sudheer.O.V. can better take care of the patient. So like I said, I'm only going to cover the pre-treatment MR. The post-treatment MR is a totally different topic, which requires a separate sort of discussion. So the first question is, why do we have to be concerned about rectal cancer? And there is a lot of press in the last 5 years, especially among the 20 to 30-year-olds. There is a dramatic increase in the number or the incidence of rectal cancer in these young patients. In fact, there is a study out that says that by the year 2030, the number of rectal cancers are going to exponentially increase in this age group to about by 124%. So clearly you can see that there is going to be a deluge of patients, especially young patients with rectal cancer, and that becomes a big challenge from a treatment perspective, because the way we treat rectal cancers not only affects the patient, but also the quality of life of the patient. So this is very important to keep in mind in terms of these alarming statistics. And also the second important point to keep in mind is that the treatment of rectal cancer is a multidisciplinary approach. You cannot, in isolation, whether it's surgery, medical oncology, radiation oncology, take care. You have to do it as a team, and in the center of the team sits radiology and pathology, because things that we see upfront in terms of staging, in terms of imaging and staging, have profound influence on how the patient is managed and also on the overall prognosis of these patients. And so what is the role of a radiologist? The role of the radiologist for accurate and precise, not only the anatomical delineation, but also pointing out to the adverse prognostic factors. And the goal is to prevent local recurrence. As you can see in this MR, this patient after therapy has had a local recurrence, and also prevent distant metastasis, as you see this liver lesion shown by the arrow. Also, the other important point to keep in mind is that in years past, for certain types of low rectal cancers, the patients used to be treated with APR resections where the patient's sphincter mechanism was, or the sphincters were sacrificed and the patient had a permanent colostomy. But nowadays, with the advent of new types of therapy, we are seeing near complete response in these patients, thereby allowing us for what is referred to as the non-operative or watch and wait management. And that's where imaging also plays a key role. So those are sort of the key questions that are asked from us and that we provide to our oncology referral base in terms of better understanding rectal cancer. So before we talk about imaging, it is important for us as imagers to understand how is rectal cancer treated. And so if the disease is organ confined, which means it is limited by the wall of the rectum, then those patients can go straight to surgery. And the classic description of the total mesorectal excision, this is what the specimen looks like. Especially if it is mid-rectal cancer, you can, spare the sphincter mechanism and do anastomosis. So if it is organ confined, you can have a surgical approach. But if it is locally advanced, as you see in this MR, it's extending beyond the wall, then you have to do chemoradiation, upfront or neoadjuvant chemoradiation. And the goal here is the neoadjuvant long course chemotherapy weakens the cancer cells, which helps radiation to work better. And the way it is done is you do chemoradiation up front, then you do surgery, and then the patient comes back and gets chemo. By doing this approach, we have taken care of local recurrence. The problem is obviously the patient has to come back after surgery and get chemo, so the compliance may be an issue. And what about overall survival or distant metastases? And that led to what is now referred to as the total neoadjuvant therapy. So instead of giving chemo after surgery, now all the chemotherapy is given up front. And how you do it really doesn't matter in terms of induction or consolidation. The bottom line is that patient gets chemotherapy up front. And when you do this, the complete response rates are up to 25%, which means the tumor shrinks down totally and is taken care of by this total neoadjuvant therapy. And when these patients go for surgery, about one quarter of them, or 25%, show complete response. And this is really an important number to keep in mind because, as I said earlier, that has led to this non-operative management or watch and wait approach. So that's, from a treatment perspective, something that is important for us to keep in mind. The next thing from an imaging perspective that is important for us to also keep in mind is that location governs treatment. When you have rectal cancers that are located above the peritoneal reflection, they behave more like sigmoid cancers. And those patients can be treated like sigmoid cancers and, surgery can be performed up front. Whereas those tumors that are below the peritoneal reflection, those require neoadjuvant chemoradiation when they are locally advanced. So that's one thing to keep in mind. Now, why is this important to keep in mind? Because the way we typically define rectum on MR, or we used to define rectum on MR, was an endoscopist perspective. And if you ask an endoscopist what defines a rectum, they will tell you that it is the distalmost aspect of the GI tract, extending 15 centimeters from the anal verge. When you sort of do endoscopy, it's sort of going 15 centimeters from the anal verge, and then you divide it into the lower 5 centimeters, which is lower rectum, mid 5, which is the mid rectum, and the upper 5, which is 5 centimeters. And I have drawn out this 5 centimeter marking on a sagittal MR. So going from the anal verge, it's 15 centimeters. Now, as you can see, if you define the rectum by this perspective, there are a couple of issues we face. The first is you include the anal canal in the rectum. The rectum length can vary among individuals. So, where does the sigmoid fall, or do you include the sigmoid or not, becomes a challenge. Because again, as I mentioned, it has treatment implications, as tumors that are located in the sigmoid can be treated with upfront surgery, whereas the rectal tumors have a different path. So this led to a sort of a change in the anatomic perspective of what we do on MR. So what we currently do in MR is we have sort of 4 key anatomical areas that we try and emphasize and locate and provide that information in terms of location of the tumor. So what are these 4 landmarks. The first is what is referred to as a sigmoid takeoff. And I will go over what this definition implies. That's where the rectosigmoid junction is. The second is the anterior peritoneal reflection. That is the point where the peritoneum inserts into the anterior rectum. The third is the puborectalis sling or the anorectal junction. And the final is the intersphincteric groove, or what is referred to as the anal verge. So let's look at what, from an imaging perspective, these four definitions are. And so the sigmoid takeoff is the point at which the rectum ends and the sigmoid extends anteriorly. So this sharp curve that you see right here on the sagittal image, that's what we see on the sagittal MR. On the axial MR, it is the point where the rectum ends and the sigmoid takes off anteriorly, and there is peritoneal insertion of the sigmoid mesocolon on either side. So this is an important landmark for us because it is important to accurately identify, because this is the point where the rectum becomes a sigmoid, and you need to know the location of the tumor vis-a-vis this sigmoid takeoff. And so here is a patient that I'm showing you where on the sagittal, as I scroll through, you can see that here is a sigmoid, the rectum coming in. Here is where the sigmoid takes off. And this cancer is way above the rectosigmoid takeoff. So this rectosigmoid takeoff is right here. The tumor, lower end of the tumor is right here. On the axial, let's finish that scrolling. And then if I go on the axial, you will see the same thing. This is the takeoff, and the lower margin of the tumor is way above the sigmoid takeoff. So this would be defined as a sigmoid cancer. Now, if there is a tumor in which the lower margin either is sitting at the sigmoid takeoff or extends below the sigmoid takeoff, then that's classified as a high rectal cancer. So here is an example where you can see that here's a rectum coming in. This is the sigmoid takeoff, and you can see the tumor is kind of touching or sitting right at the sigmoid takeoff. So this would be classified as a rectal cancer, whereas this previous case that I showed you would be a sigmoid. So that distinction is important because that has treatment implications. The second is the anterior peritoneal reflection, and we can identify this very nicely on MR, and it's important to know where the anterior peritoneal reflection happens in the rectum, both in male and in female patients. And so in this case, as I scroll through, you can see that this subtle black line so this is a male patient. As you can see, this is a prostate. Here is a seminal vesicle. So right at the tip of the seminal vesicle is where the peritoneum extends posteriorly and inserts on the anterior margin of the rectum. That you can nicely see in this image. There's a little bit of free fluid that is kind of outlining the peritoneal reflection as well. So that's, again, at the tip of the seminal vesicle, the black line that extends posteriorly. That's sort of the peritoneal reflection anteriorly onto the rectum. It's an important landmark to identify. What about in women? In women, it is the point where the uterus and the cervix join, or the junction of the uterus-cervical junction, where again you see this black line. This is a young patient. You can see there is free fluid, which is expected in premenopausal women, outlining the peritoneal reflection. So this bright layering fluid nicely outlines the peritoneal reflection as it inserts into the rectum. So that's where it normally is in women. And on the axial image, you can see as I'm scrolling, again, this is a female patient. This is the mesorectal fascia right here. This is the rectum. As I'm coming up, this black line is the peritoneal insertion. And as I'm coming up higher, you can see that there is fluid, bright fluid that is present in the peritoneal, deep peritoneal recess as it inserts into the anterior part of the rectum. And then as we go into sigmoid takeoff, this is a sigmoid mesocolon on either side, or the peritoneal reflection of the sigmoid. So it's important for us to identify the peritoneal reflection. So the third is the puborectalis sling, or the anorectal junction. And typically, if you ask the pathologist where they would define the anorectal junction, and their answer would be the dentate line. That's where the columnar epithelium becomes the squamous epithelium of the anal canal. The problem is we cannot define, or we can't identify the dentate line on MR. So do we have an indirect measure of where the dentate line is? And one easy way of knowing where approximately the dentate line is you draw this on the sagittal image. You draw this line that goes from the inferior margin of the pubic symphysis all the way to the lower margin of the coccyx. and that sort of defines the anorectal junction. If you were to do an axial image, where does this fall approximately is where you have the puborectalis muscle. So this U-shaped muscle that you see, which is outlined in blue, and in another patient right here, that's sort of the, and that's what the surgeon feels with their finger. It's called the anal shelf. Now, this is a little bit higher than where the typical dentate line is, but it's a rough estimate of where you would gauge the dentate line to be. And lastly is the anal verge. What do you define as the anal verge? Now, ideally, you would define it where the anal canal ends and the skin, sort of the skin that surrounds the anal canal begins. But if you look on the sagittal T2-weighted MR, you see that this black line right here is the external sphincter, and this right here is the internal sphincter. And what we typically define as anal verge from an imaging perspective is where the internal sphincter ends. So you may ask, well, why aren't we taking the external sphincter? Why are we taking the internal sphincter? The answer is, it is more predictable in terms of where the location of this is. Sometimes when the patients are taken for surgery, they're given anesthesia, or when they do endoscopy, this external sphincter may relax. And so the internal sphincter is more predictable in terms of measurement, and that's why we use the internal sphincter as the landmark on MR. So knowing these, the question is, when you're looking at the case, is the tumor at or above the sigmoid takeoff? Because that governs whether it's a sigmoid cancer or whether it's a rectal cancer. You give the distance from the anorectal junction, and you also give measurement in terms of distance from the anal verge. What is the significance of the peritoneal reflection? That is more in terms of staging, and we'll be talking about that. So with that in background in terms of anatomy and a little bit about rectal cancer, now we dwell into the actual MR, how we do it. And it's a relatively straightforward exam. Before I begin, one important point to emphasize is, as MR imagers, we are not in the business of detecting rectal cancer. It is very important that when you scan a patient for rectal cancer and when you stage the patient for rectal cancer, you need to know that the patient has had a biopsy, because many a times anal cancers can be higher up and mimic rectal cancers, and rectal cancers can extend down into the anal canal. So you'll be wrong in terms of detecting. So we're not in the business of detection. We are in the business of staging rectal cancer. That's an important point to emphasize before we start. So we start with the sagittal view, and it's sort of an important view because that tells you where the tumor is located along the axis of the rectum, and it's also an important initial anatomic sequence to start with. After we do the sagittal image, we do a true axial, and that goes all the way from the anal verge, a little bit below the anal verge, up to the level of the aortic bifurcation. And the reason for doing an axial is to look for lymph nodes, is to look for ancillary findings in the pelvis. Following that, we do what is referred to as a high resolution thin T2-weighted. This is sort of the money sequence for staging. Why do we want to do, and what is the meaning of a oblique high resolution? So on the sagittal, if you see here is a tumor, we are going perpendicular to the barrel of the tumor. And the reason we do that is because it gives us a better anatomic definition of the wall of the tumor, better anatomic definition of the mesorectal fascial outline, and also of other surrounding anatomic structures. If you don't do this, you may end up staging the rectal cancer. And let me show you an example. So this is a true axial image. And here is a tumor right here. And if I ask you, looking at this image, whether this tumor is locally invasive, which means it is extending beyond the wall or not, you can see that there posteriorly it is very unsharp. And one may say, well, we think that there is tumor going beyond the wall right here. The same patient doing a true an oblique axial, you can see that actually the tumor is within the wall. It's confined to the wall of the rectum. It's not extending out, as you can mislabel right here. So that this oblique angle is exceedingly important. So please, make sure that if you do rectal MR, or at least tell your radiologist to, do these oblique axes. Sometimes, depending on where the tumor is located, like for example, right here, this is straddling the sigmoid takeoff, you may have to do two obliques to correctly stage the tumor. And so that's, again, an important point to keep in mind. After that, we do a coronal T2-weighted MR. And again, this is to look get a separate look at the angle of the tumor, but also very important, this plane is exceedingly important in the low rectal cancers. And so when you have a low rectal cancer, you want to see the relationship to the sphincter muscle because that is what the staging requires. And so here is the plane of the axis as I'm showing you. It should be along the plane of the anal canal. Only then will you see this nice depiction of anatomy as you see the levator ani muscle, the puborectalis, the external sphincter, and the internal sphincter. You want the anatomy to be nicely laid out like this. Otherwise, you are going to, again, not have the adequate surgical information to provide your oncology colleagues. And then diffusion, which is a standard sequence we use for looking at a different property of the tumor. It enables us to detect the tumor and also if there are any locally advanced features. And then this is a little bit of controversy. At our institution, we give contrast to all the patients. There are some who don't believe in giving contrast. And again, it's sort of, if you have a group of radiologists who have varying levels of experience and expertise reading, it sometimes helps to have gadolinium on board. And also this is good as a baseline when you're comparing it to post-neoadjuvant therapy imaging. So now let's look at some of what the poor prognostic determinants. We saw how the exam is done. Now, when we read the exam as imagers, we try and identify certain poor prognostic determinants that can help, again, the referring oncology team decide on how best to manage the patient. So let's start with this first one, which is the mucinous and signet ring pathology or subtype of adenocarcinoma. What are some of the MR features that can suggest that? When you have bright signal, and bright we mean like fluid bright. So here are this is a male patient. You can see this is the seminal vesicle where there is fluid in the seminal vesicles, which is bright. And this tumor has bright signal just like the fluid in the seminal vesicle. So when more than 50% of the tumor has this bright signal, you call it mucinous. This is another example where the tumor is localized to the wall. And as I said, having these mucinous tumors imply worse prognostic factor. And you can see, although this tumor appears to be confined to the wall, this patient actually has liver metastases. So knowing this feature and identifying helps you better look for local spread or even distant spread, because mucinous tumors, mucinous subtype of adenocarcinomas are usually worse actors in terms of prognosis. The signet ring is another subtype, which is a very challenging tumor because this is typically seen in younger patients. It is not as bright as the mucinous. It's bright, but not as bright. But the key factor here is it spreads along the inner wall of the rectum and uses the wall of the rectum as a scaffolding to spread. So, you can see the extent of the tumor is fairly long here. You can have a preserved wall of the rectum, but despite that, these tumors typically have worse outcome. The fortunate part is they're not very common. And so, when you do see this on the pathology of the endoscopic biopsy, make sure you look very closely in terms of truly defining the extent, because it may be way longer than what you see or expect. So, again, something to keep in mind. The next thing is the T stage. And, if you look at how we can adequately stage, if the tumor is confined to the wall, then it is typically T2. Once it extends beyond the muscularis into the surrounding mesorectal fat, it is T3 stage. And we have A, B, C, and D depending on the extent. If it is less than a millimeter, it is A. If it is T3B, that is 1 to 5, and T3C is 5 to 15, and greater than 15 is T3D. And so why do we have this sort of gradation? You have this gradation because the cutoff is 5 millimeters. Tumors that are under 5 millimeters, they have an exceedingly good 5-year survival. It drops precipitously to less than 50% if it is more than 5 millimeters. So then you may ask, well, why don't we just have less than 5 and more than 5? And the answer is, in certain practice patterns, having early T3 disease is is taken up as T2, and these patients sometimes may go straight to surgery. Again, that depends on where you are and which and your local sort of surgical preference pattern. So that's why from an imaging perspective, we provide these measurements, and this is how you grade it, A, B, C, and D. But the bottom line is 5 millimeters is the cutoff. So that's on the T staging to keep in mind. The next is extramural venous invasion, and as the name implies, it means that the tumor is spreading beyond the wall into the surrounding venous structures. And so here you can see in this example there is a expanded signal within the vein which mimics the primary tumor, and having this sort of a extension into the venous structure, or EMVI, implies bad prognosis. And these patients, typically, you have to look very closely, as is in this case, the patient has liver metastasis seen on the CT. This is a different patient, female patient. You can see the uterus anteriorly. And here is the upper rectal cancer you can see extending into the vein. We know it's upper rectal because, again, here is a sigmoid takeoff. It is reaching just below the level of the sigmoid takeoff. So it is an upper rectal cancer, and it extending into the venous structure, expanding it with a similar signal intensity as the primary tumor. So that's what EMVI looks like. But what about this? So here we are looking at an oblique axial image. This is a female patient. So what you're seeing, this is a urinary bladder. This is the cervix, and here is the rectum. And you can see a little bit of free fluid in the peritoneal reflection. As I scroll through, you can see that there is a vein that is emanating from the posterior wall of the rectum. And as I scroll through, you can see it sort of expands and then becomes normal in caliber, and then again expands and again becomes normal in caliber and again expands. So there is discrete nodularity along the venous structure, unlike what I showed you earlier, where there was homogeneous extension. So what do you call this? These are called tumor deposits. And this is sort of the description, where if you have tumor directly going into the veins and expanding the veins, that's the EMVI. But in this case, you have normal caliber venous structure followed by expansion of the lumen and then normal lumen again. So that's what tumor deposit looks like. Now, if you look at the current end staging, the tumor deposits are N1C, but they clearly have a worse prognostic outcome compared to even having lymph nodes. So I think I'm told that in the new AJCC classification, which is currently being worked out and soon to be released, that these probably will be placed higher than having lymph node deposit. And so this is another example just to looking at, and so here there is a polypoid lesion, as you can see right here in the rectum. And as we scroll through, you can see posteriorly there are normal veins that are emanating. And as we follow these venous structures, you can see there is expansion, again, normal caliber, and again, there is expansion right here. So this is what tumor deposit looks like. And you need to comment on that and call out these tumor deposits. But what about lymph nodes? And I think from a nodal perspective, it's important to understand what is regional and what is non-regional lymph node. This is the peritoneal reflection right here. And typically tumors that are at or below the peritoneal reflection, one needs to keep that in mind, because when tumors are at or below the level of the peritoneal reflection, they can spread to pelvic sidewall. Whereas if they're above, the typical drainage pathway is mesorectal nodes going along the axis of the inferior mesenteric vessels. These pelvic sidewall nodes have received a lot of attention recently, and there are two distinct groups. We have the internal iliac and the obturator nodes, as is shown in this diagrammatic depiction. So you can see the blue outlines the internal iliac chain, this green outlines the obturator chain, and the red is the external iliac chain. So the obturator and the internal iliac are considered regional for tumors that are at or below the level of the peritoneal reflection. External iliac is considered distant metastases. That's not considered regional lymph node. And 7 millimeter is the cutoff if you are to be looking in this location. So when you have a tumor at that location, pay close attention to the pelvic sidewall. And by definition, they say you draw a line along perpendicular to the internal iliac vessels. If you have the node that is medial to that, that's an internal iliac node. If the node is lateral, then that's an obturator lymph node. What about inguinal nodes? When tumors they involve the anal canal, then it can spread to the inguinal nodes. And the reason why we need to call attention to that is because if the patient does get neoadjuvant radiation, then this has to be included in the radiation field. And so keep in mind that they are for low rectal tumors, these involving the anal canal, this can be regional nodes, and one needs to keep that in mind. So that's regarding lymph nodes. Now, what about looking at the peritoneal reflection, as we said earlier, and the mesorectal fascia status? So as we said, the T3 disease is when the tumor goes beyond 15 millimeters and almost touches the mesorectal fascia. That has an adverse prognostic factor. Here is a normal peritoneal reflection that you see, and this is what it looks like on PAT specimen. So you can see that there is circumferential cancer, but there is no extension into the peritoneal reflection right here anteriorly, and it's still T3C disease. It's abutting the peritoneal reflection, not really involving him. So one has to make that distinction. As opposed to this case, in this patient, as I'm scrolling through on the axial image, you will see that here is the outline of the mesorectal fascia, and this is where the peritoneum insert. There clearly is a nodular extension going through the peritoneal reflection into the peritoneal space, and this would be T4A disease, and again has bad prognostic implications. So important to call attention to that when there is extension into the peritoneal reflection. And then the last prognostic thing is low rectal cancer. How do we, as imagers, what are the key points we need to communicate? So the first thing is it at the level of the levator or is it in the anal canal? If it is at the level of the levator or the puborectalis, you measure the shortest distance to the levator muscle or the puborectalis. So as you can see in this case, there is a tumor extending laterally to involve the levator. When it does involve the levator ani, it becomes a T4B tumor. And again, an important point to communicate, because these patients then, depending on how they are managed and subsequently what kind of surgery they undergo, they may have to extend the dissection and take the levator mechanism as well as the sphincter complex. But what about the tumors that are in the anal canal? When the tumors are in the anal canal, we have a descriptive outline. We don't typically use the AJCC T staging. We think about it from a surgical perspective. So what you're telling the surgeon is, when I have a low rectal cancer in the anal canal, is it involving the internal sphincter? Is it involving the intersphincteric space, or is it involving the external sphincter? If it is involving the internal sphincter, it's still T3 disease, and depending on how it is managed, the patients can have sphincter sparing surgery. But if it goes into the intersphincteric space or involves the external sphincter, then those patients typically have to have sphincter loss and may require a permanent ostomy. So here is an example on the coronal. Again, remember we talked about the oblique coronal. This is why it's important to accurately delineate the anatomy. You can see this is confined to the internal sphincter. This bright area that you see right here is the intersphincteric space, and this is the external sphincter. So clearly there is no tumor going into that intersphincteric space. And so this patient, depending on the treatment, can have sphincter sparing surgery. Whereas in this case, you can see that there clearly is tumor extending into the intersphincteric space beyond the internal sphincter. The other side is maintained. You can see the nice fat between the two sphincter muscles. And then lastly, here is an example of a tumor that is involving the external sphincter. And so in this case, clearly, if they end up doing surgery even after therapy, depending on how much tumor is left or not, this patient will have to undergo a extended APR. So with that, in conclusion, I've emphasized that the rectal cancer management is a multidisciplinary team approach with radiology and pathology at the center. I showed you the 4 key areas that one needs to emphasize: the sigmoid takeoff, the peritoneal reflection, the puborectalis sling, and the intersphincteric groove. Do not forget to look at the pelvic sidewall nodes, which are exceedingly important. And then for low rectal cancer in the anal canal, think about it from a surgical perspective and look at the anatomy very closely, especially in the oblique coronal, so that you can give the adequate information to the referring oncology team. Thank you so much.
That was
Thank
a
you.
mind-blowing presentation, Dr. Harisinghani. And you made the black and white images very colorful. Thank you for the wonderful presentation. Over to Dr. Sudheer.
Yeah, it was a immensely beautiful presentation. Thank you very much for giving us the idea how to read a MRI scan in the case of rectal cancer and what are the pitfalls in reading it. Now, actually, I have a couple of questions before going to the chat box. Dr. Mukesh, the thing is, many of the times we find this tumor, the MRI staging, a little overstaged. For example, when you do a local excision of the tumor, probably it might have interpreted as T2 tumor or even sometimes T3. But when you go for a a transanal endoscopic operation or TEMS, the report comes as is only a SM3. And also, we might have gone for an anterior excineration, we think that there is a tumor is infiltrating the prostate. But the report comes as it's only aborts, it's not infiltrating. So is it only because of the differences in interpretation of the images, or is there anything that can we do better in interpretation in these cases? Yeah, thank you.
No, excellent question and point. I think, like I said, the technique is very important. If you don't do the adequate planes, then there is a high likelihood. Now, remember, rectal cancers entice a lot of inflammation, and that inflammation can sometimes appear as what may be perceived as disease going beyond the wall. So one has to look at all the images and then make the best, staging interpretation. Now, I'm in the camp that I always say that no imaging is 100%. We always are operating on what we refer to as an ROC curve. We give our best probability of what we see, and then leave it in your able hands because you know the patient well. You have seen the biopsy. You understand what the molecular appearance of the cancer is, and then make a informed decision. But to answer your question, I think it's important to emphasize that if you don't do a good technique, that's when errors are bound to happen. A lot of times I see, when I've traveled in India and given lectures, I see that many institutions use the same protocol for imaging the bony pelvis, for imaging the prostate, for imaging the rectum. That is very, it's very inappropriate because what ends up happening is then you're not putting your best foot forward. So one has to tailor the exam for rectal cancer rather than just use universally one protocol to assess the entirety of the pelvis. But that's a good point. I kind of emphasize we are not 100%, but if your technique is good, then you can at least provide the best possible guesstimate of what the staging is going to be.
So there is no standardization of MRI techniques or MRI sequences in the cancer?
There is standardization, and there are recommendations, and we have local and international bodies that have put out technical documents that are very easy to obtain and follow. And I would encourage highly, if you are in a specialized center where you're doing rectal cancer, that you should follow those technical parameters.
Okay. One more question I would like to ask is now, usually, when you stage the, in a post-operatively, the pathologist stage the tumor, they need some 12 nodes to adequately, stage the tumor. But we never look into that when you go for an MRI scan. We go for the T and the node and all, but not the number of nodes. Do you think that is important to count the number of nodes involved to accurately stage the tumor?
Yeah, so I'll tell you that we are lymph nodes is our Achilles heel. We are really not good at staging lymph nodes. What we can tell you is whether there is presence or absence of pelvic sidewall and inguinal nodes, and what is our index of suspicion. But as far as the mesorectal lymph nodes are concerned, although there are parameters out there that describe it, we still don't do a very good job. So our goal is, from an imaging perspective, is to tell you whether there is presence of suspicious node or not. Beyond that, it's that the distinction between N1, N2, N3 is not very difficult for us because we are never going to have the accuracy to tell you.
Yeah. And what about PET MR? Does it has any further advantage on?
No, because adenocarcinomas of the rectum, they don't have a ubiquitous high signal on FDG PET, and so they, in fact, it could be a lot of times they are not FDG avid, and in that case, you may falsely assume the tumor is not. So I would not recommend that.
Thank you. So we'll go to the chat box.
Before that, I take this opportunity to give a token of gratitude to Dr. Bhavana Parikh, who has introduced Dr. Harisinghani to me. Thank you, Dr. Bhavana.
No, thank you.
Yeah, go ahead.
Yeah, there are some questions. Mucinous tumor post-RT response assessment, how to interpret and plan extent of resection. That was a question by Dr. Surya Narayan. You have some comment. Mucinous tumor post-RT response assessment. I know it's difficult. Yeah.
Yeah, no, I think, again, mucinous tumors are very difficult because what ends up happening is you cannot on imaging tell the difference between cellular mucin and acellular mucin. So what ends up happening is I showed you how it looks like. It's very bright and it's like fluid. We call it, the patient gets neoadjuvant therapy and then we re-image them. It looks exactly the same. I cannot tell you if the cells are dead or they are still active. And so that again, one has to assume with the mucinous pathology that these are worse actors and they'll have the worst outcome. So at least in our setting, our oncology team is overtly aggressive with these tumors. And I'll tell you one other thing, which is interesting anecdote, is that as I mentioned, younger patients are getting rectal cancer. A vast majority of them actually are mucinous subtype, which makes the management even more difficult.
Yeah. One more question is, what should we ask to the radiologist? Should it be a contrast enhanced MRI or a plain MRI is enough?
Yeah, so I think, as I mentioned, it's a matter of debate. We use contrast. Obviously, in the Indian setting, it's tough because it's expensive. If you are not going to use contrast, you need to make sure that your other sequences that I showed have to be of the best quality and with the relevant planes so that you are able to provide the necessary information. So it's a matter of local, preference.
Yeah, and the talk itself, he has already mentioned that.
Yes. Yeah, another is just a surgical question. Is there a surgical approach which can preserve the internal sphincter in IAS invasion? Yeah.
I think you are a better person for that.
So if the groove is the sphincter groove is not involved, then there can be a subtotal or total intersphincteric excision where you can go the length, you can come down onto the anal verge, or you can end where you want. So yeah, there are techniques for that. That was by Peter John. Yeah, there are a lot of congratulatory messages in the chat box. Is there a difference giving intrarectal gel for distinction of rectum being staging? That was by Dr. Shim Malik.
Yeah, no, it's kind of tough to go through all, but yeah, if you are able to do that, distending the rectum with a little bit of gel or microenema is actually desirable because fluid in the rectum helps better delineate the outline of where the tumor is. It also helps in some of the other sequences where it suppresses the gas that can sometimes, be a problem for us. So yes, if you're able to do that and your practice allows you to do it, I would highly encourage that you do that. So.
Yeah. One more question it was being asked is how to differentiate between tumor deposit and the lymph nodes. That anyway you have discussed, I think, in your description about the tumor deposit and the lymph nodes.
Yeah, as I mentioned, it's discontinuous and continuous. Yes.
Yeah. Then that contrast has been explained. So many people are saying that it's lucky to attend this class. How do we identify the sigmoid cutoff in axial view? That also you have
Yeah.
explained the peritoneal reflection
He
and all.
must have joined after that only. Dr. Rajesh, you have raised your hand. Can you please go?
Thank you, Baiju. As usual, fantastic lecture moderated by Sudhir and Mukesh. So question from my side is, I practice in England. So we got a special GA radiologist looking into MRI scan of the rectum, and their job is to do routinely only checking on GA radiologists. So how about subspecialization of the radiology into the rectal cancers, rectal MRI? First question. Second question, in UK, sometimes opposite to Sudhir, what he commented, we wait, the patients wait for at least 4 or 5 weeks to get a date for surgery. So in this stage, sometimes a T2 cancer becomes T3 cancer. So when is a cutoff to say, okay, this patient needs a repeat MRI, waited for 4 weeks or 5 weeks or 6 weeks? Do you have a cutoff for waiting or repeating the MRI when the patient has waited too long? So these are my two questions, but excellent presentation from Mukesh and Sudhir.
Yeah, I'll
you.
take the first one. I think that certainly is desirable if you have a experienced reader looking at it. In fact, the American College of Surgeons, which provides, they have a mechanism through NAPRAC where they accredit sites for rectal cancer. They want to have a dedicated radiologist looking at this in the multidisciplinary setting, and they have some criteria. The dedicated radiologist has to attend at least 50% of the multidisciplinary settings. So, the good thing is the radiologist gets feedback when he or she is not correct, or when he or she is correct. And so that kind of builds on their experience. So yes, I definitely agree. If you have the ability to do that, that's highly encouraged. Obviously, that's not possible in all the settings, so you have to make do with what you can. But if you have the bandwidth to do that, it's certainly desirable. I'll let Dr. Sudhir answer this.
Truly, as you said, Dr. Rajesh, it's always desirable to get a MRI close to the point of surgery to see what's the tumor stage. I would say that 2 to 3 months or 3 months waiting for a surgery is probably too much. But most of the cancers that we get here probably might need a neoadjuvant treatment. So that waiting period, we can accommodate them. You give the neoadjuvant treatment and then wait for, up to 12 weeks. Then you go for the surgery. Probably we might get that time, and you can schedule the patient accordingly.
Yeah, Dr. Alex Mutri, can you please?
Yes, thank you to the foundation, thank you to the moderator, and thank you, Professor, for a wonderful presentation. I've always wondered what the clinical relevance of the longitudinal length of the tumor is. It's always stated in our MRI reports, the measurement in terms of the tumor is this long. What is the clinical prognostic relevance of that information?
Yeah, so that's an excellent point. It's not important with rectal cancer how long the tumor is in the lumen, it's how radially extending outward it is. So, it may be exceedingly long, but if it is confined to the wall and is a T2 tumor, then obviously it has better prognosis. The one that you worry about is the radial extent, which is how much it goes outside the lumen or the wall of the rectum, rather than how tall it is or what is the length of the tumor. The length may become relevant when the tumor is located low down in the rectum, because obviously if it is straddling the middle rectum and extending into the anal canal, then obviously it has surgical implications. But in terms of just pure prognostic factors, it's more the radial extent than the actual length of the cancer.
Thank you. Dr. Uma Bharadwaj.
Actually, sir, good evening. It was a very nice session that was given by you. I had two queries. One, in cases of rectal cyst, what are the things that we can, added findings that we have to note down on our imaging? And the another question was the same question that was asked previously, that when should we repeat the imaging? Because if we are getting delayed for surgery due to the workload in government setups, usually So, like the ideal time to repeat the scan, or is there an arbitrary range that within a month if we repeat, or should we repeat it 3 months, or should we repeat it for every patient whom we are taking up for an upfront surgery?
Yeah, no, so I think if you're going directly to surgery, depending on the staging of the tumor, you want to be as close to the surgery as possible. If you do neoadjuvant therapy, then the typical recommendation is 8 to 12 weeks because you want to give time for the neoadjuvant therapy to act. You want those changes to be visible. And then depending on what you find at 8 to 12 weeks, then appropriate decision is made. Either you can continue following or you will take the patient to surgery, whatever is the desired treatment paradigm that is followed at the local institution. So that's regarding the follow-up timing. The other is what other things you talk about. I think, there are subtle nuances to surgical. I did not go into all. I tried and emphasize those that are very important. But each institution, I think what is important is, before you start a rectal imaging program is you need to sit down with your surgeon and decide with them what is the key points that they are going to be wanting from you in terms of decision making. That is exceedingly important because even though you have a template, that you can download from any of the website, it still is very important that you need to understand from your surgeon what he or she is going to be, or in terms of points that they will look in terms of decision making. And then you can add those things to the addition to the template. But that's what I would say is it's very relevant there to have a open discussion with your surgeon. Otherwise, it sometimes is a miscommunication and a mismatch between what you're saying and what they want from you.
Yeah, I would say that the other way also is true. The surgeon has to sit with the radiologist before surgery and really study the MRI very well. Many of these things, the internal iliac node, the obturator node, its relevance, everything is very, very important. I would say that the surgeon should sit with the radiologist before surgery and study the MRI very well before planning any treatment, neoadjuvant or non-operative treatment or whatever it is. It's very important. So the invasion of the external sphincter is T4B, or how is it being classified? No, it's T4B, I understand.
Yeah. So any striated muscle involvement, whether it's levator, puborectalis, or external sphincter, is T4B. Yeah.
Yeah, and what I understand is now there is no more threatened mesorectal margin. It's either involved or non-involved. This 1 to 2 millimeter is not there.
Yeah, because that's very tough to look from a resolution perspective. So yeah, it's that terminology is no longer used. It's either yes or no. So this way you can decide on best way to, because obviously it's important for you to get a clear surgical margin. And so by us saying yes, then accordingly you can decide what best to do.
Yeah. Yeah, and I know you are not planning anything on the sequential or the second stage CT MRI scan after the neoadjuvant, but still that's again a big important topic. But we in India also we do a lot of cases now, neoadjuvant and watch and wait or non-operative management or local excision of the tumor, where MRI interpretation is very, very important. Very important.
Yes. I know it is very critical, yes. And like I said, it's a whole topic in itself.
Exactly. It's a whole topic.
There is a lot of exceedingly good papers that are coming from the Indian, from Tata and other places in India. They are doing really phenomenal work. So I'm sure there is a big body of experience and expertise that we can also learn from. But yeah, thank you again for giving me the opportunity, and thanks again for everything.
Thank you, Dr. Sudheer and Dr. Harisinghani, for giving us a wonderful topic and a wonderful lecture regarding MRI images in rectal cancer. And thank you, Dr. Sneha, for introducing the moderator and the speaker. Thank you, Dr. Bhavana, again for introducing Dr. Harisinghani to me. And thank you all the participants who have joined from all over the world. for this. Actually, we reached nearly 450 participants. That means that the total login will be nearly 1,200 or 1,300. Thank you all once again. If you have any further queries, please write to me or write into the WhatsApp group. I'll be conveying the questions to Dr. Harisinghani. Thank you.
Thank you. Thanks.
Thank you. Thank you very much. Thank you.